Welcome to Datafest 2024. So, it being a data event, I thought it was quite pertinent to kick it off with a fact, a data fact. So, as you can see up there, by 2030, it is projected that data-driven healthcare interventions could save over 1 million lives in Africa annually. I'm going to let that sit with you for a second. 1 million lives. That is an immense number when you think about the impact that data can have on healthcare challenges on our continent. So one of the things Georgie didn't mention is I was doing this data and AI thing before it was very cool, because as you can see, I'm not very cool. And now that it is cool, I am still not cool. But what I can tell you is that in my 3 decades, in my 30 years of doing data, I have seen it deliver unimaginable value. Unimaginable value. And what gets me up every morning when I work at the Aga Khan University is when I see the potential of EHR data in terms of what it can do, in terms of it being a game changer for the continent. But before we get into that, I'd like to set some context for you. So we know within the region, on the continent, etc., we suffer from a lot of healthcare challenges. In fact, in Sub-Saharan Africa, 213 million cases of malaria annually, with the majority of that being within the East Africa region. When it comes to HIV, just in Kenya alone, we have 4.8 million people living with HIV, just in Kenya. And from a global HIV burden perspective, East Africa accounts for 25% of the global HIV burden. Maternal mortality. We still are grappling with maternal mortality. In East Africa, the average is 556 maternal deaths per 1,000 live births. The global average, 211. We are 250% higher than the global average. This is a common thing that happens every day, and hopefully will happen to the 67% of the attendees in the room at some point. And we are 250% above the average. With urbanization, we have NCDs on the rise, non-communicable diseases. On average, in East Africa, 27% of the deaths are from non-communicable diseases. And the last stat that I'm going to give you is, to top this all off, look at our ratio of total healthcare workers to 1,000 people. In East Africa, it's 1.9. The World Health Organization recommends 4.5. We are less than 50%. So now you might say, okay, Farhana, you know, all we need to do is we need to invest in our infrastructure. We need to invest in our healthcare system because, you know, the high-income countries, they know how to do this. Well, you know what? I'm here to break your bubble. Because when we borrow, it actually doesn't always work. I'm going to give you 2 examples. The first example is in colorectal cancer. Colorectal cancer in Kenya is 3 times higher than it is in a high-income country. Screening in high-income countries start at 50. 40% of those that have colorectal cancer in Kenya are less than the age of 40. So we can't borrow. Another common fact that is known, 30% of human cancers are usually detected by a mutation in a gene. That gene doesn't exist in our population, so we cannot use the same care protocols, the same algorithms that you have in a high-income country. We have to innovate for our context. Given these challenges that I've walked you through, showing you that we can't just borrow, we can't just bring and import in protocols seamlessly, we need to innovate and innovate for our context. And we've done this. George walked through what we've been able to do from an innovation perspective. Think about M-Pesa. Kenya is the leader when it comes to mobile money. Like, you know, when you look at one of the high-income countries that is touted as being sort of a global leader, in the United States, tap on a device, I don't know, it's 4 years old, 5 years old, and think about 79.4% of adults use M-Pesa product. We completely skipped over that brick and mortar financial institution and jumped right to the digital age. So why can we not do that when it comes to addressing these healthcare challenges? We've done it before. And that's what gets me up every morning, is when I see the art of the possible. We are able to do this again. The art of the possible in harnessing not only that EHR data to be that transformative change, but in the context of our communities, of our countries, of our genetics. And why do I say this? If you look at EHR data, it's comprehensive. You have all of the patient information, you have lots of data, it's real, it's longitudinal, you're able to identify care gaps, whether it be within the healthcare setting or it can be within the region and the community, and you can help address it. It's cost effective, etc. There's a lot of potential there. And what your potential is by harnessing EHR data is your ability to then predict. The ability to predict and move to disease prevention versus disease prescription. And we have success stories in our region, on the continent. I'm going to give you two. I just want to make sure I get the stats properly. So the first one is in Tanzania when it comes to maternal and child health. So at the Ifakara Institute, what they did is they implemented an EHR, and it helps track maternal and child health. And you can see the stats. A 30% decrease in maternal mortality and a 25% decrease in neonatal mortality. And how did they do this? Honestly, it was simply by tracking maternal child health, being able to intervene early, and making sure that when you had high-risk pregnancies, you ensured that you had higher care practitioners. That was it. But it was harnessed and actioned based on an EHR. Another great example is diabetes in Uganda. And that's where you had the Makerere University partnering with the Ministry of Health, and they implemented an EHR to track diabetes across multiple clinics. And so not only do you have your patients receiving comprehensive care, what you were able to do is they stuck to the treatments, and you had a 20% decrease in diabetes-related complications, such as vision loss or amputations. Better data, better outcomes, contributing to that 1 million lives saved from data interventions. And so we here at the Aga Khan University see this potential. And so we've begun on our project. So we've had an EHR system in our hospitals for quite some time, but we've never harnessed that data. We use it for record keeping. So now what we're doing is we're harnessing that data, and we've built a repository of anonymized records from Nairobi, Mombasa, and Kisumu. So you're taking into consideration 3 regions. It has the typical data, your ICD-10 diagnosis, your labs, your tests, and we continue to add to this repository at a regular cadence. And so what we want to use this repository for is research. For research to help drive that number from 1 million to hopefully 2 million or 3 million in terms of data-informed interventions. Better data, better outcomes. And so we're early in our journey. We've only just completed phase 1, but I want to walk you through some of the work that we're doing. So the first is around cardiovascular disease. Cardiovascular disease is that is epidemically rising in Kenya. Estimates show that 25% of hospital admissions and 13% of deaths in Kenya are due to cardiovascular disease. So we pulled a bunch of data, and it's early, but one of the interesting observations, and I will say as a scientist, observation, so please do not take this for fact, is we've noticed that, I'm going to get the medical term right, the return of spontaneous circulation after a cardiac arrest, it's called ROSC, within our environments is between 58 and 67%. In a high-income country, looking at journals, it's 45%. So we are higher. We are doing this better. And what is it that we are doing that is different than a high-income country? We're speculating. We don't have all those machines that they have in high-income countries. When somebody goes into cardiac arrest, see these two things? That's what we use. It's hand-on-chest pumping, and that is much more effective. And so that is one of the studies that we're doing. Another one that we're doing is around gestational diabetes. This is truly looking at preventative, proactive care, right? Being able to intervene early, like they did in Tanzania, right, when it came to maternal mortality. And so gestational diabetes, as you can see from the numbers there, is high in Africa. And it has more complications for us because we do not have the type of health facilities that you have in a high-income country. However, it's diagnosed between weeks 24 to 28. And so what we need is we need earlier diagnosis so we can intervene sooner. And so what we're working on is developing machine learning models using this data. And then the last area I want to talk about is using large language models. So George mentioned, it's been mentioned by Philip, generative AI has a lot of potential. So what if, we talked about the 1.9 healthcare workers, what if we were able to help that one healthcare practitioner that is out there in Kilifi taking care of 1,000 patients, and all of a sudden there's a cholera outbreak? What if he were able to ask, in a natural question, hey, what have we done in the past? What has worked for cholera? What prescriptions, what care protocols have worked? And we're able to tap into this repository to leverage what has worked before and answer him. So it's not just him, himself, and him, but he actually has the knowledge, the history, the trends of what is happening. I've just given you a glimpse of what the potential is in terms of unlocking EHR data. EHR data, or EHRs, we have Meditech in the audience, are known to be great record keepers. They increase efficiencies, they increase productivity. You're able to automate several things. But what I'm challenging you to think about is, do not think about it as just a record keeper. I have a saying, we live in a world where we have so much data, yet we are data rich, but insight poor. We suffer from drip. And what I'm challenging you to do is, with EHRs becoming more common, do not let us suffer from drip. Let it be a transformative catalyst. Let it be that game changer and help us move towards that utopia of making proactive preventative care a reality and not something that we strive for. Thank you very much.